Welcome to the CAREcast.
Hi everyone and welcome to this CAREcast, and I'm here with Dr. Gillian Wright, who is a researcher for Care Not Killing. Care Not Killing is an umbrella organisation, a coalition of groups who are opposed to any change in the law when it comes to assisted suicide and euthanasia. And recently, or certainly very shortly, Care Not Killing will be launching a brand new grassroots campaign with Our Duty of Care to encourage doctors and healthcare professionals to join that campaign against any change in the law. Dr. Gillian Wright, thank you for joining us on the CAREcast.
It's a pleasure. Thank you for having me.
Where are you from, Gillian? Can I start there? Which part of Scotland are you from?
I'm from Glasgow, from the west of Scotland.
Fantastic. So just for everyone watching or listening, we've got a East Coast, West Coast divide happening right now. I'm from Edinburgh on the East Coast, and Gillian from the West Coast. There's not going to be any Glasgow, Edinburgh problems on this podcast?
Really not. There's only ever one place that you should be. So.
Fantastic. And we're going to talk about end of life issues. We're going to talk about assisted suicide and euthanasia. And actually, let's just start there. People use different terms when it comes to this debate. You'll hear the term assisted dying used a lot. So I wondered if you could just talk us through the key terms, and is there a difference? Don't they all just basically mean the same thing?
They don't actually, and I think it's a really helpful place to start. So assisted suicide is when the doctor prescribes a medication such as a barbiturate, something that we would use perhaps at a low dose for seizures, but they prescribe at a high dose, and they give it to the patient at their request, so that they can take it at a time of their choosing. So it's very much the doctor assisting the person to commit suicide. Euthanasia is quite different because it involves both the prescription and the administration. And so usually it involves the administration of a lethal injection. And so you can see how that could be both voluntary and involuntary. So they're quite different. Assisted suicide is just the prescription, and euthanasia is both prescription and administration. And quite often at the moment we hear the term assisted dying, and that tends to encompass both. And I think it is sometimes misleading, and it does help to use the two distinctly, because assisted dying could mean a number of things, whereas assisted suicide and euthanasia are much more clear. And at present, both of those are illegal in the UK, but there have been a number of bills before Parliament over the last 20 or so years asking that they might come into force, but so far have been resisted.
One of the things that kind of complicates this issue as well, just from a policy perspective, is that the Scottish Parliament can legislate in this area under its own autonomy, and then the Westminster Parliament can do so for England and Wales. So you could have multiple attempts at the same time. That's happened before. And there does seem to be, if you are on Twitter at all, you're watching the news, a growing pressure to change the law, both in Scotland and down in England and Wales as well. What do you think is driving this increased support, or apparent increased support, for changing the law to legalise some form of assisted suicide?
I think that's a really interesting question, and I think there's probably a number of factors. I think one of the main factors is that death is scary, and I think all of us, or maybe most of us or all of us, sometimes will feel anxious about death. And so when you're actually facing death, that can be really difficult. And I think people are scared not only of death itself, but also of the process of dying. And so the concerns about whether there might be pain or suffering or perceived indignity, although that may not be the case. I think people have real concerns about that. And I think also that comes alongside changes in our society. So we have noticed probably over the last 50 years or so that the perspectives in our society have changed. So people are much more used to choosing things. They're much more used to their rights. It's much more consumerist society, if you like. Whereas perhaps 50 years ago, it would be a much more duty-based or doing things for other people, community-based. And so this kind of sense of autonomy or patient autonomy has really marked medicine, often in very good ways. But I think it has, in some ways, collided with this concern about death and ignited this debate yet again.
The funny thing about death, death's always been part of being human. It's not new. Yeah. Why do you think, given that there's been such increases, for example, in medical technology and medical understanding, death seems scarier than ever? Why do you think that is?
That's an interesting point. There's probably a number of reasons. I think we're in an increasingly secular society, so I think there's less assurance or reassurance about death, and also I think there's less of the extended family in that sense, so people are perhaps maybe more isolated at times. And I think I was mindful of coming to do this CAREcast with you, that there might be people listening who are anxious about their own situation, and in this time of social isolation, of social distancing, there may be people who find discussions about assisted suicide quite upsetting. And I would be, I suppose, encouraging of people that if they do find this discussion upsetting or stressful, that they should really find someone kind to talk to. If these thoughts are going through your mind, then please do talk to a friend or a neighbour, the Samaritans. That there will be someone who would be glad to talk to you. So I'm just mindful of that as we embark on what is an abstract concept in some situations, a policy decision, if you like, but to other people who are facing really difficult situations, it's very much a family or situation, and I would just urge people to be quick to ask for help.
That's really helpful. Thank you, Gillian. Just going back on that point you raised around autonomy and this cultural shift that's taken place from maybe a duty-based attitude towards my rights becomes the dominant thing. This is the argument we hear again and again. It's in newspaper columns, it's on the radio, it's on TV. This is the argument for changing the law and allowing doctors to prescribe that medication to help someone end their life. It's my right to choose how I die. And I'm just curious, what would you say to that argument, to someone who was saying to you, this is all well and good, Gillian, but it should be my choice, what I get to do at the end of my life? What would you say to that argument?
Well, I think it's complicated in some senses. I think it's really important to listen to where they're coming from. I think people have a whole situation and a story that is really important for us to listen to and not just dismiss. But I also would really want them to think about what is important about choice. And choice has marked modern medicine in a way. So patient choices are hugely important, and it's changed medicine in a good way. So I think doctors must respect patient decisions and patients' input, their opinions, their background, and it has changed medicine from a kind of relentless paternalism of this is best for you because I know best, and that's really, really a good place to have come away from, if you like. But I suppose I'm concerned that we would get to the stage where choice is unlimited. And even in normal life, we don't have unlimited choice. So what I do affects you, what I do affects my family. And we accept that. We accept that we can't do everything we want. And if we live in a community, then my choices affect other people. And even just in a practical sense, when we go out and drive a car, we put our seatbelts on, we stop at the red light, because we know it's the next person's turn, and we accept that all this give and take is part of a society. So I suppose my argument would be that we're used to safeguards, if you like, we're used to safety decisions. The question is where, and if there is deemed that there is a harm to other people, then I think you have to draw a line there.
It's so helpful to be reminded of the fact that in our day-to-day lives we accept limits. And I suppose just thinking about the last 12 months, I mean, surely if there's
Absolutely.
ever been a season where we've had to accept limits for
Yeah.
the benefit of others, it's been the coronavirus pandemic. You've actually argued in letters to newspapers up in Scotland, for example, that if we legalized assisted suicide, so if we did change the law, that would actually reduce the autonomy of the most vulnerable in our communities. I wonder if you could just explain what you meant by that.
Yes, I suppose I'm concerned that there might be a very small number of people who would want assisted suicide or euthanasia and campaign for that. But I think as a doctor, I think you have to be responsible and consider all the people that also might be in the ward and the effect it might have on them. And I suppose I'm really concerned when you look at, say, a country like Belgium, where euthanasia has been legalized since 2002, and you look at their rates of involuntary euthanasia. So that's when there's no explicit request for euthanasia at all. So a patient who's perhaps confused or unconscious, and the doctor has administered a lethal injection, and they have evidence, they document that their rates of involuntary euthanasia are about 1.7%. So that's 1 in 60 deaths. And so I suppose I'm concerned that the familiarity with taking life would lead us to the stage where it becomes acceptable that those sorts of things would happen. And Belgium's not a million miles away. It's not so different societally in structure, but they've just accepted it for a considerable number of years. And so that's one aspect, that there would be an involuntary euthanasia. But there's also a second aspect in that I think people would feel pressure. So I think there's a lot of older folk or people who are weary and tired and struggling with their illness who just feel that they're becoming a burden on their family and their friends. And certainly that's one of the reasons that's documented most highly in people asking for assisted suicide. It's not the only reason, but becoming a burden or being a burden is something that they do find upsetting. And so I suppose I would be concerned that if we made it legal, then we would suddenly have a duty as a doctor to explain that that's a possibility. So your ordinary person coming to your clinic, asking about what the options are, and you're explaining about pain relief or palliative chemotherapy, maybe a dose of radiotherapy, and then you'd have to say, but actually there's also an option that you could choose to end your own life. And I think folk who've never even considered it would suddenly think, that would be real release, and it would help folk like my daughter who doesn't want to take time off work, and folk who don't want to visit from far away. And I just think they would get the impression that they weren't really valued by us as a society, and I guess I'm concerned about that. So both those aspects of absolute involuntary euthanasia, but also of perhaps more subtle pressure.
Gillian, we're going to take a break just now, and we'll be picking up in the second half of this CAREcast in just a few moments. Just to add to what you said as well, just really struck by that fear that you talked about, people afraid of being a burden. And, I guess as a Christian public policy charity, we've often reflected on that fear of being a burden and what's a kind of Christian answer to that. And I often just think, I think a Christian response is to say, yeah, you might well be a burden, but that's okay, because we're all a burden. Like, we're all a burden in different ways at different stages in our life, from, when we're a crying baby and need everything done to us. And then that you come full circle, and that may happen again at the end of your life, or indeed at any stage. And it's a better story to say to people in that situation, that's okay. We want to help you, love you, care for you. Yeah, really helpful.
I agree. And I think one of the most rewarding aspects of palliative care actually is looking after people and their families, because you see how, not always, but a tremendous amount of families looking incredibly well after their loved ones. And that's just a wonderful part of society, that might happen.
Fantastic. We'll be back in just a few moments' time for the second half of this CAREcast, so we'll see you in a few moments' time.
Thank you.
Join us for Care Sessions, a series of online events helping you to effectively engage with and stand up for the issues that matter to you. Join us in March for 2 live Q&A sessions. To find out more and to register, visit our website care.org.uk/events. Spread the word and see you soon.
Welcome back, everyone, to the second half of this CAREcast. My name's James. I'm the Head of Communications at CARE, and with me today on the CAREcast is Dr. Gillian Wright, a researcher for the coalition group Care Not Killing, who are an umbrella organisation, lots of different groups, part of that coalition, opposed to any change in the law when it comes to assisted suicide and or euthanasia. Gillian, we're going to dive into evidence now, because there are countries and states around the world where either euthanasia or assisted suicide already legal. And as you think about the evidence from these different places, how does it highlight some of the risks that are involved with any change in the law?
I think it's very clear that when the law is changed, then it almost inevitably leads to further changes down the line. And I think you can consider somewhere like the Netherlands, which brought in euthanasia about 20 years ago. Initially, it was very stringent. It was for people within who were suffering at the end of their lives. It was for adults. And now that has changed. And so they brought in a protocol for disabled babies. So it is possible now to have euthanasia for babies up to the age of 1 and who are profoundly disabled. And that's called the Groningen Protocol. They're currently discussing whether it could be for children under 12, and for adolescents it is possible. And also there has been a change in the type of illness. So initially it was mostly terminal illness, but now it's possible for people with multiple pathologies, so much more commonly the elderly, so maybe who would have some heart failure, bad arthritis, poor eyesight, those kind of things. And yeah, it's much easier to get euthanasia than it was before. And also it's possible for psychiatric illness, which it wasn't before. And the same is true in Belgium. There has been a real slippery slope. I think you would have to argue that things have changed over the last 20 years, and certainly there have been children under 12 who've been euthanized, people with dementia and with depression, and really these are the folk that you'd want to safeguard euthanasia or assisted suicide for, and yet it's becoming much more common. So one of my concerns is that assisted suicide legislation is potentially discriminatory. So for patients, for example, who have motor neuron disease, they can have extremely limited hand function and so aren't able to take the medication themselves. So if the law was such that assisted suicide was brought in, then those who campaign for end-of-life decisions for motor neuron patients wouldn't be allowed to access that. And so there would be immediately a campaign for euthanasia for motor neuron disease patients. And so my concern is that if you allow one aspect of taking life, if you like, or killing patients, then that will in turn open the door to others.
Something that Care Not Killing is in favour of, and certainly we at CARE, working with politicians across the UK, have championed, is palliative care and the importance of palliative care. Just for those listening who perhaps are unaware of what palliative care is and what it seeks to do, could you just touch on that briefly?
Absolutely, yes. Palliative care is really an approach, a way of looking after patients in the last part of their life. So it can be just a few weeks, but it can be more than a year, depending on the diagnosis. So we would have looked after patients perhaps for a short time, maybe for pain control, and then they would have gone to the cancer specialists for a while and then perhaps come back to us. So it is a way of trying to look after the whole of the patient and their family as well. And so because of that, you try and look at different aspects. So not just looking after their physical symptoms, although those are really important and can comprise things like pain or breathlessness or poor mobility, but also looking after psychological symptoms, so maybe anxiety or depression, looking after their social situations, so perhaps enhancing access to benefits or looking at housing, and palliative care social workers are extremely important in the team, and also dealing with spiritual aspects, because questions of meaning and purpose in life and wondering about the value of life, those are really important questions and should be addressed by all palliative care professionals as part of their assessments and management of patients facing the end of their lives. Palliative care is delivered by a number of different people, so it can be delivered in the community. A great deal is delivered in the community by GPs and district nurses, but they do other jobs as well. They obviously do, look after babies and orthopedics, all sorts of other things. So they're the generalist team, if you like. And you also get a specialist palliative care team. So that's who we think of in terms of Macmillan nurses or specialist palliative care doctors. And they can be based either in the hospitals, so as a specialist team, or they can be based in hospices, which is what most of us think of as palliative care, but it's actually only part of palliative care. And hospices are just wonderful places to work, and they're a real team effort, and a great way of super nursing care, really good problem solving, and support for families. We don't get it right every time, and there's not always perfect access, and things are not always perfect, but as a model, it's a really good model of care, and it really was pioneered in the UK. And some of you may have heard of Dame Cicely Saunders, and she was just a great shining light, a visionary, if you like, for palliative care. She initially was a social worker, and then was a nurse, and then a doctor. So she was like a multidisciplinary team all by herself. But yeah, she was great. Yeah, really good.
And of course, one of the powers of palliative care is that it can be and is effective in terms of pain control and pain management, because I think that's often the kind of the point that people need to be reminded of, that this isn't just some kind of airy-fairy, nice talking, but actually it works, doesn't it?
Yeah, absolutely. And I think there's an enormous amount of good that you can do with palliative care. And actually, quite often when patients used to come into the hospice, I wouldn't always change their medications in the first 24 or 40 hours, because there's just a relief at being there that often reduced their pain. And one of the things that they often talked about was that they felt safe, whereas they'd been really anxious at home. And that was a real joy, actually, to have people feel safe, because the nurses were looking after them. They knew where they were. And it's not for everybody. Some people would rather be at home. They want to be at home in their own house, with their cat and their dog and whatever. But it's possible now to do both. It's you don't want to be misleading. Some symptoms in palliative medicine are very, very difficult to manage, but they are the exception. There are some people who have very difficult times, but the majority of symptoms can be managed incredibly well, and we should be able to reassure people about that. But also, we need to give people access to that. So I think there's a real burden or drive that this debate should be contributing to, is that there should be excellent and good access to palliative care. The UK is good in terms of worldwide, but it could be better. And yeah, it could be better. We could have more education, we could have more research going on into these difficult symptoms. I think I read recently that there's 0.2%, so 0.2% of all research budgets in the UK on health are on palliative care, which is really small. And if some of that balance was redressed and it was going into new painkillers, that sort of stuff, which is going on in really good departments, like in Edinburgh. Actually, I might even grant that there's a fabulous palliative medicine research unit in Edinburgh. But yeah, so there's lots that can be done. It doesn't need to just be palliative. It doesn't need to just be assisted suicide.
That's really helpful. I think it's something that, at CARE, as hard as we've worked in the past to resist changes in the law to legalise assisted suicide, we've also supported proactive attempts down at Westminster in particular to try to address the issue of the availability of palliative care. And Baroness Finlay in the House of Lords down here has been a champion of that cause.
Yeah.
Gillian, we're just running nearly out of time, but I do want to finish by just getting practical for people who are listening or watching on YouTube. It's really important that people engage with their politicians on these kind of issues, particularly as it looks like there could be votes happening in the Scottish Parliament after the election, whether that's in May or later, and also down at Westminster as well. There's always a possibility of a vote coming. So just as people think about engaging with their MP or maybe their member of the Scottish Parliament on this particular cause, just some practical pointers just as we bring this to a close.
I think that's really important. I think the main thing is to do it. I think it's quite a daunting thing to speak to somebody in authority, but I would really encourage you to take the opportunity. The times I've always been really encouraged how willing they were to listen and how helpful they were actually. So I would really just encourage you to take that opportunity to either to email or to go and, when circumstances permit, to talk to them in person or to do a Zoom call at the moment. I think if you can explain your concerns, ask them questions, perhaps tell them about your family situation if it's pertinent, your experience of good palliative care or your concerns about the lack of access to palliative care. And those are issues which can be addressed. I think CARE is doing a fantastic job. I think really getting informed about the different developments that are ongoing at the moment, knowing when things are happening, knowing about practical things that are happening is really important. And I think supporting CARE in that way is really helpful. And yeah, absolutely, we're just keen to support that. Thank you.
Fantastic. Well, if you do want to find out more about some of the questions, some of the things that Gillian has talked about and that we've discussed on this CAREcast, then I really would encourage you to go to the CARE website, care.org.uk. If you find our cause section, there's an entire cause that's all about end of life, and you'll find resources, you'll find a raft of different content from facts and figures, as well as arguments both for and against, to help you understand where different groups are coming from. So please do go to care.org.uk to find out more about this cause. Gillian, thank you so much for the work that you're doing and for giving us your time today.
It's been a pleasure. Thank you so much. Yeah, thank you.
You've been listening to the CAREcast. Remember to subscribe to get the latest episodes and find out more about the work of CARE on care.org.uk. CARE, for what you believe.